Welcome, everyone, to Talking Back to Suicide. This is one of your hosts, Dr. Diane Kaufman, though I like to be called Dr. Diana for my creative self. I'm a poet, artist, Humanism and Medicine awardee, a retired adult and child psychiatrist, and I'm the founder director of the Hold On campaign for suicide prevention that inspires hope by creating resilience. Using the powers of art making and experiencing, we educate, connect, express, and heal. And my co-host, Kino Isaac, is coming to us from South Africa. Kino is a DJ, music producer, entrepreneur, and most importantly, a mental health advocate for independent artists. Our special guest today on Talking Back to Suicide is world-renowned suicidologist David A. Jobes, PhD, ABPP. Dr. Jobes is a professor of psychology, associate director of clinical training, and director of the Suicide Prevention Lab at the Catholic University of America. His research and writing have produced over 150 peer-reviewed publications, including 6 books on clinical suicidology. He is a past president of the American Association of Suicidology, AAS, and recipient of that organization's 1995 Edwin Schneidman Award, the 2012 Dublin Award, and the 2016 Marsha Linehan Award, all in recognition of his research contributions to clinical suicidology. Dr. Jobes' outreach as a suicide prevention consultant is formidable and includes his providing service to the Centers for Disease Control and Prevention, the National Institute of Mental Health, FBI, Department of Defense, Veterans Affairs, and many more. He was a featured expert in the PBS 2022 Facing Suicide documentary. About the Suicide Prevention Lab, their website states, the research focus in our lab is broadly centered on suicide prevention. More specifically, we tend to study suicide risk assessment, both quantitatively and qualitatively, and treatment of suicide risk in different suicidal populations across a range of clinical settings. Perhaps most importantly, our group at CUA has developed a novel therapeutic approach called the Collaborative Assessment and Management of Suicidality, CAMS, which is suicide-focused, evidence-based clinical framework. In recent years, we have been extensively engaged in randomized clinical trials of CAMS. Through replicated outcome across trials, we know that CAMS quickly reduces suicidal ideation, depression, and overall symptom distress while increasing hope and clinical retention to care. So with all that, warm welcome, Dave, to Talking Back to Suicide.
Thank you, Dr. Diane.
Yes. So I want to say, when I was looking at your website, of the many impressive features on it and the work that you're doing, I was also impressed with all the smiling photos of your team, right? Including a young researcher wearing a crown in one of the pictures. So I wanted to ask you, suicide for many, and maybe for all, is a depressing topic.
Yeah.
How do you maintain your personal optimism and help support your researchers in that?
Well, first up, Diane, I'm so grateful to Kino and you for having me on today. I really love to have these opportunities to talk to a broad audience about this topic. Yeah, I've been at this for over 40 years, and people will say, oh, what a depressing field and expertise. And I was like, we save lives. We decrease suffering. The biggest single effect for CAMS is increasing hope and decreasing hopelessness on a 9-study meta-analysis. So we've lost patients in trials, and that's horrible. And many of your listeners and viewers have probably known people who've died by suicide. I certainly have. As a clinician and as a person, there have been losses. At the same time, I really feel like the joie de vivre of the lab is a feeling like we're making a difference in the world. Because the thing I'm most focused on, Diana and Kino, is really decreasing suffering. And the field is the academic field is very preoccupied on reducing completions and attempts, which I totally get. But in the United States, there are 16.9 million Americans who have serious thoughts of suicide. And that's a massive, massive number of people. And the field kind of like doesn't actually sort of focus on that. We're so preoccupied, for example, in randomized controlled trials, of decreasing attempt behaviors as an outcome measure. I am too. And CAMS does do that and decreases self-harm behaviors. But CAMS is the best intervention for decreasing suffering and symptom distress and suicidal ideation. And that's a lot of people in the United States and also abroad, obviously.
Could you define suffering? It's a subjective word, but maybe there's objective ways to understand it.
I mean, there are measures like the OQ45 or global severity, and there are different ways that clinicians and researchers quantify or talk about suffering. What I'm talking about is a kind of suffering where the person who's struggling, and it's not just depression, it's not just anxiety, it's a kind of an angst or a exquisite suffering where the person comes to the conclusion, I need to end my life to escape this level of pain. Ed Schneidman, one of the founders of the field, was keen on differentiating suicidal suffering. He called it psych ache. And psych ache was a construct that he liked to make up words, but among the words they made up was this idea that psych ache is different and unique. It's not just depression. Depression can be awful, as we all know. It's not just anxiety. It's not just having a bad day. It's a kind of suffering where the solution is suicide. In the mind's eye of the person who struggles in that way, it can become very compelling. And we know by midnight tonight, 135 Americans will have done that. So that's our mission. That's why the students and myself in the lab are so passionate, because we feel the majority of people that are going to die by midnight tonight probably could have been helped actually on an outpatient basis, and that a lot of the conventional wisdom of what people think works actually maybe doesn't help or even makes things worse. So we're on a mission, to really bring evidence-based approaches to really the people that struggle in this way.
Could you say more about that, Dave? You said things that we think may help, may not help, or may even create harm.
Yeah. So, I mean, a common perception is that suicide and depression are synonymous, but there are millions of people that suffer around the world who are clinically depressed, have dysthymia, have bipolar disorder, who never think about suicide. So it's not true that suicide and depression are synonymous. And then, if we have 135 that are going to die by this evening on average, about 50 of them will be clinically depressed. Diagnostically, others will have psychotic disorders or substance abuse disorders or character, different kinds of personality issues. So we've had kind of a simplistic notion that if you treat the depression, that will reduce suicidal ideation and attempt behaviors and death. But that's not what the evidence shows. What the evidence shows is that treating suicidal ideation and suicidal behaviors independent of diagnosis is what reduces suicide risk. So, and this is not opinion, this is based on, for example, there was a Pew Foundation survey of Joint Commission's accredited hospitals about doing basic low-hanging fruit, what I would say, every hospital should be doing, for example, around safety planning type interventions or lethal means discussions or care transition for somebody coming out of the hospital, which is a very high risk period, as you likely know. And most accredited hospitals are not doing these things reliably. And what we also clearly know is that a very brief hospital stay, maybe with great insurance, a week or 10 days, the person is probably coming out in some ways at greater risk.
Yes.
Which shocks a lot of people. You think, oh, something must happen in a 3-day stay that means that this person's better on the other side. But that's not what the data shows. And in fact, there are some recent sort of big reviews, a scoping review out of Australia. Involuntary hospitalization is significantly associated with much more increased risk of suicide and other deaths. So we've got to improve our hospital practices and or work with people on an outpatient basis using things that actually work and not rely on things that actually may increase the risk. Serotonin selective reuptake inhibitors, SSRIs, are antidepressant medications that carry with them some measure of activation, which can be therapeutic, as you know, but it could also push somebody over the edge if they have suicidal thoughts on board. So in a kind of a simplistic way, hospitalizing somebody, getting medication on board is probably the modal response, when in fact the thing that's actually going to work are these outpatient therapies like CAMS and others that actually can keep somebody out of the hospital and will reduce their suicidal thinking and prospect of attempt behaviors.
Thank you. Just to be transparent with you, Dave, and our audience, I myself had attempted suicide when I was in medical school, and it was my intent was to kill myself, and I took a prescribed medication that I knew could kill myself, and my fantasy was just that I was going to fall asleep and not wake up. Of course, I wasn't thinking at all about any of the external consequences, my dorm mate coming back to the room, my family, my friends, etc. That was not in my mind at all. It was, as you said, that the emotional pain I was feeling was unbearable. And in my situation, I was having thoughts that I didn't deserve to live. And I was medically admitted to the hospital, and years later was diagnosed with bipolar 2 disorder. Thankfully, my crossing the line into suicidal behavior absolutely frightened me. And I knew that I potentially could get there again. So that was a protective factor in wanting to take care of myself. I've had a family member who died by suicide, a mental health colleague who died by suicide, a psychiatric nurse practitioner who, even being the parent of 2 sets of young twins, could not save her from her psychiatric illness, and 2 patients, an adult with chronic pain and a teenager. Many of those events fueled my own passion for suicide prevention. And I want to say that sharing my own story, because what happened after I attempted suicide in medical school, I didn't tell anyone. I didn't speak of it aloud until I was about 60 years old. So there's tremendous shame. Here I am, a psychiatrist. Okay? A lot. Could you speak about that shame? Because isn't it true, most people who actually they attempt the suicide, they don't tell anybody.
Yeah, I mean, what you just shared is, to me, so important, because you're describing the state that people are often in when they conclude this is the thing to do. And Ed Schneidman, who's one of the founders of the field, used to say it's a bad idea to kill yourself when you're suicidal.
Yes.
And what he meant was that you're probably not problem solving well. You've probably lost kind of a perspective. We know, as a psychiatrist, that depression is constrictive, and that we sort of lose the range of problem solving skills. The prefrontal cortex is oftentimes kind of offline, and we're not problem solving or looking at things more in a balanced, sort of rational way. And so people like you are changing the field. What I mean by that is that people with lived experience are kind of coming out of the woodwork and saying, this was my experience on an inpatient unit. This was my experience of getting a safety plan. And a lot of that is being listened to, like people like me saying, wow, I thought this was this or that was that. We did a qualitative study, Diana and Kino, where we asked people about post-suicidal life, this construct that I had been writing about. And people were like, I don't really love that. They kind of dismissed it and said, this is a part of who I am. That's your need for me to kind of get over suicide. And they're right. And so I listen to folks like you and to others that we talk to are systematically studying qualitative interviews. And the good news is, to me, that these voices are changing the field. And between a combination of evidence of what actually works and people lived experience kind of telling us what it's like, I think we're seeing a possible tipping point from what I would argue is like a medieval mindset, a really antiquated notion that the best response to someone who's suicidal is a carceral, controlling, you can't do this, with enforcement. That's why I'm not a fan of involuntary hospitalization. I know that there are exceptions, and you may have viewers or listeners that feel that this is necessary. As a parent, I get the abject terror that your child might do something and you want to stop them at all costs. And I suppose there are always exceptions. But the vast majority of people that we study and that I've worked with as clinicians can be effectively cared for on an outpatient basis with certain precautions taken, of course. So you're speaking to the experience of what that was like. You're also speaking to the idea that we know from research that there are people that where it's a one-off, it's a one and done, and they they're scared straight, if that's a term that kind of fits. And then there are people who made 2 or more attempts, and folks that have made multiple attempts are different altogether. They've gone to the well, the bar is a little bit lower. Each successive attempt actually increases the likelihood that they'll eventually end their life. So, I mean, all that is really a valuable perspective on this topic.
The other day, Dave and Kino, I started watching a film on Netflix. It's called The Iron Claw. Do you know that film? It's about, I'm not going to get the name of the wrestling family correct. Maybe it's something like Von Erlich, where it's a film based on a true story. The father, the patriarch, was a wrestler. He had about 4 or 5 sons. They all became wrestlers, and many of them award-winning wrestlers. About 3 or 4 of his sons died by suicide. And in the film that was created, there was a younger son, who also died by suicide. But the filmmakers, from what I read, did not include that son in the film. And somehow artistically, they sort of combined the 2 youngest sons to be one person. But from what I've read, it was because it would have been too depressing for the audience to know that another son died by suicide. So I know that this family is unique, and there was also concussions, I imagine, from wrestling. There was pressure to be a wrestler. There was also drugs and alcohol. There were relationship problems. But to have a family where there's 3 or 4 suicides at young ages as well. And I want to link this to, isn't June Men's Mental Health Month?
Sounds right.
As well.
May is Mental Health Month, so.
Yeah. So I think May is Mental Health Month, but I think June is Men's Mental Health Awareness Month. Could perhaps you and Kino also talk about men and their mental health?
Yeah, Kino, you want to take it up?
Oh,
mute.
Can't hear you.
Oh, sorry, I was on mute.
Yeah.
For me, it's all the same. Men's mental health month, women's mental health month. I mean, mental health is an issue, 365. I don't understand, and I don't want to criticize, the founders of a specific month that's dedicated to men's mental health. Okay, but I mean, it's an issue that, as I said, it's 365. It's going to still be there after that month is concluded. So, well, I don't know what's the history, Dave. Maybe you know what is the history of a month dedicated to men's mental health?
Because men need it. I mean, three quarters of our suicides are men. So men are killers. Men are, commit homicide, and men take their lives much more than women. So, and then there's all kinds of things that follow from that. But, men are much less treatment seeking. Men are much less healthy than women. So the gender effects in the suicide prevention business are huge. So men are in need. And I don't know if these designated months make a difference, but in the suicide prevention business, men are a big problem. In fact, the 2/3 are basically middle-aged white males who have major depression, and they have alcohol problems, and they have firearms. And so that's the challenge. I mean, so much focus is on youth, and I get that. Yeah. We have several RCTs, randomized control trials, with teenagers and college students and so forth. But to be blunt, the deaths are with the middle-aged white males who are firearm owners, and those folks are tough to reach. They don't go to their primary care doctor. They don't go to a dentist. They don't, they don't take very good care of themselves. So I think that's the reason that there's a focus like that. I will say I did an interview for the Men's Health, which is a men's magazine, several years ago, and welcomed the opportunity. But it was another example where I spoke to this excellent journalist about suicide prevention and the challenges that men face. And I think I spent 3 hours with her. It's a great story. And at the end, there's a little carve-out box. Help is on the way. A medication was still under FDA review, ketamine, which can be helpful. Nothing about the psychological treatments that we talked about.
Oh my goodness.
And she said, my editor, intervened and sort of put that box in at the end. And I was like, well, but that kind of blows the whole story, which is that there are these psychological suicide-focused treatments that nobody knows about that actually been proven to work. And yet people routinely get hospitalized and they routinely are prescribed antidepressants. And, those can be helpful, of course, but what is going to carry the day are these suicide-focused treatments that people just don't get.
And say again your thoughts on why it seems so obvious to me. Why are people still not receiving these services, or they're known?
I can speculate with the best of them. Honestly, I submitted a paper to a journal called American Psychologist, which is published by the American Psychological Association. It's the high impact journal. And we simply said, as psychologists, we should be ethical and do things that work. And there are 30 years worth of randomized controlled trials of interventions and assessments and things that work. We should use them. That was the article. And what I want to share is that I fully expected a desk rejection. I really have become so skeptical or cynical, frankly, after all these years, of people kind of like coming around to these ideas. And the good news is, not only was it not desk rejected, it got a spectacular review. And I'm saying that not so much to brag as to say, maybe there's hope that we can get a tipping point here. But I think to your question, Diana, we just don't want to accept that people can do this. And so we're going to make them not do this. And we're going to lock them up, and we're going to put them in restraints, and we're going to chemically, manage their impulses. And, I do get that, but it doesn't help. And in fact, it makes things worse. And so there's not a journalist I talk to or a podcast that I go on where we talk about this, and people are like, really? They just either can't believe or don't want to believe that what we think is effective is actually not. Let me put it this way. I have a colleague named David Rudd. He's a very good friend of mine, and he and I do randomized controlled trials. He has this more recent idea about looking at outcomes like suicide attempt, suicidal ideation, hopelessness, and say overall symptom distress. 4 different outcomes that we routinely look at in RCTs, randomized controlled trials. And David has argued, and I think we're working on a paper, I'm not sure where that is, but has argued what we really would like to see are reductions in all of these, all 4. And that would be an actual recovery or remission. And yet there'll be people today who are hospitalized where their ideation isn't down. They're not less hopeful or less hopeless. They're still distressed, and they're still at risk for attempting, and they'll be discharged. And the difference between having all 4 of those go down, which he calls a full recovery, versus a partial recovery, which is maybe your ideation goes down and maybe you feel a little bit better. When you, as a physician, that you wouldn't admit somebody to the emergency department who's got multiple fractures and contusions and just treat 2 or 3 of them and leave the rest. You'd want this person to be cared for. All the bones are set, all the lesions and are sewn up and taken care of. And yet in mental health, we routinely discharge patients who actually are not doing that much better. So mental health is not physical health, it's not surgery, but we do kooky things, we being the field of mental health, that we know come up short, but we do it anyway. And that to me makes me crazy. I just can't stand that we do things. How many people do I talk to who are like, well, we did a Columbia and a Stanley Brown safety plan. And my response to that is like, good. You're not using a no harm contract, and you're actually using an assessment tool that has valid and reliable results. That's just the beginning.
Yes.
What about all the things in between and treating what makes this person want to kill themselves? And that oftentimes like, oh, well, I don't, we don't do that. And why don't we do that?
Making me think how we can potentially call someone, you're mentally sick. Okay? Sick in without quotation marks and with quotation marks.
Yeah.
Versus you are suffering.
Absolutely.
And that is a big difference.
I've never talked to a person who was suicidal who wasn't legitimately suicidal, who didn't have very good reasons for entertaining the end of their life. And instead of judging that or labeling that or shaming that person, as we talked about a little bit earlier, we should be empathic of that. We should be responsive to that. In our treatment, we have, this may sound crazy, in the CAMS intervention, we ask the patient, what makes you want to take your life? and they tell us, and it's mostly relationship issues. With some of the teenagers, it's very existential or social determinants. I'll always be in debt. The earth is dying. They'll say things like that. And then what people do, and in our intervention, we treat those things, and we call those drivers. And when we treat drivers the best we can, we can use medicine, but we mostly are doing like couples therapy, or we're doing vocational counseling, or we're doing behavioral activation or cognitive therapy. When we treat those drivers, we don't have to eradicate them for someone to do and be much better. We just have to change it a little bit. And that's why the biggest effect for CAMS is increasing hope and decreasing hopelessness, because it doesn't have to be eradicated. We just have to know that there's a way that this thing can be improved upon, made better, or I can feel a little bit better. It's not a light switch. It's a rheostat. It's like changing your relationship to suicide, establishing stability, being able to manage the thoughts and feelings. And then at the back end of the intervention, we talk about what would make your life worth living, which is an idea that Marshall Linehan developed in dialectical behavior therapy, but we really operationalize it in the treatment.
I'm remembering in surgery, right? Didn't they develop some sort of checklist that became policy? I don't know if I'm remembering this correctly.
You are absolutely
Maybe it was related to instruments being left in a person after they've done the surgery, or maybe you've taken out the wrong kidney, that there's a checklist that people follow. Why isn't there a checklist in psychiatric care, especially around admissions to a hospital and then discharge?
It's another great question. I can simply say you're describing what Joint Commissions refers to as, I'm blocking on the term, but these are adverse events that shouldn't be happening. And all I can say is we don't have treatment guidelines in mental health for psychiatrists, psychologists, social workers, counselors to follow. I do a lot of policy work. I'm in DC. That's why I do all this DC stuff. We tried to get, the different guilds to talk to each other. Just couldn't even start the conversation. There's just too much turf battles and issues between psychiatrists and psychologists and social workers, to sit down and say, we need sensible guidelines. That's the American Psychologist paper, which we can maybe pass along to you. It just described, these are the things that work. These are the things that are readily available. You can download. These are the interventions and treatments that work, not just mine, but other interventions, and we should use them. That's the gist of that paper, which seems so to us, the three of us, obvious, but apparently not to the field. And I can say, from another angle, which maybe isn't lost on any of us, a big factor in what drives clinician behavior is fear of malpractice. So because this is a growth industry for plaintiffs' attorneys, to sue a provider or a clinic or a hospital or all the above for wrongful death, where the plaintiffs, which are typically grieving families, and I get that grief, and I certainly have seen as an expert witness terrible care, iatrogenic, harmful care, but there's a lot of clinicians who've done actually a really good job, and certainly met the standard of care, but they get sued anyway. So what that reality means is that a lot of clinicians then practice defensively, or a lot of policies are defensive. And that means hospitalizing people or keeping them in the hospital, or, calling the police, so it ends up being the thing that helps people is autonomy. The thing that's done is carceral and restrictive. And so that's a hard thing to change. What we need is tort reform, frankly. What we need is more discerning plaintiff work or malpractice work, where egregious cases should be adjudicated. But so many of these cases are good clinicians who did their best and didn't deviate from the standard of care to get sued anyway. So that's a part of the problem too.
In terms of clinicians, so that could be the MDs and the social workers, the psychologists and other providers. To what extent do you think that there's inhibition in forming a therapeutic relationship, even though you want to, and that's your purpose, because it can hit too close to home, right? Right? If I were a nephrologist, I would be treating the kidneys, or the person with the kidney, but I don't have a kidney disorder. Right. But in mental health, we bring our own baggage, as it were, and also family. And does that influence what's going on?
There's a paper written in the 1970s in the Archives of General Psychiatry by a psychoanalyst named John Maltzberger and his colleague Dan Bowie. And they talked about suicide, the hatred of suicidal patients. And And it was a very provocative paper for the 70s to talk about hating a patient. And but it was a very famous paper. And what they talked about was malice and aversion, that the person who's suicidal represents a threat, maybe because of your own vulnerabilities or sensitivities to the topic. But yes, I mean, clinicians are afraid of people that are suicidal, which shocks a lot of families or even shocks patients that aren't you trained? Actually, not. Most mental health professions across our disciplines are not trained. We mostly learn on the job. And a lot of what is learned is this medieval model that is, evolved to the present day, that is not based on evidence. So it's kind of kooky. I mean, that the people that the public or journalists or the general public assume are experts are not. And what actually works is not what's brought to bear typically. So with exceptions. So I'm speaking generalities and there are exceptions. But clinicians have to learn about becoming less afraid of these patients. As a physician or as a surgeon, they lose patients all the time on the table, post-operatively, in the course of primary care. They don't try to get rid of these patients. They don't not do surgery on a patient that needs surgery. Mental health professionals try to get rid of these patients, which to me is horrific. Exceptions, of course, always exceptions. That should be the asterisk to the whole talk today. But they're afraid. So what's interesting to me is in the Collaborative Assessment Management of Suicidality CAMS, we have the clinician take a seat next to the patient with permission to go through a tool that's assessment and treatment planning and the treatment plan for drivers, and the patient gets copies of the document that we're completing. If you could, we can do it online as well. But it required in the development of this to kind of get somebody literally on the same side, looking at suicide, to actually join with this person versus looking down on them. And what we find is that young people that we train, or people, I have a colleague in Eastern Kentucky University who runs a clinic with doctoral students in psychology. And these are second and third year PsyD students who use CAMS, and they're expert at working with suicidal risk. They want to work with suicidal people. They're eager to demonstrate their competency because they don't have attitude. They care about the evidence. They're not afraid, and they like being effective, which is why we love training young people. People my age, forget about it. They know everything, and they're not receptive. But young people are, and that's why we really focus on training young clinicians, and they can become competent in something that most licensed providers are terrified of.
Or residency programs incorporating CAMS in their didactics and intervention.
They're not. If they're incorporating anything, they're incorporating a kind of a diluted version of cognitive therapy. They might make reference to dialectical behavior therapy. I mean, we know that there's a lot of psychology and counseling programs that are training in CAMS. We have a training company that's all we do is try to get clinicians trained. We've trained 60,000 clinicians. That's not bad. We train all over the world. That's good. But there are 16.9 million Americans who are suffering. So it's a drop in the bucket, and this is a tide we're trying to change. It's really so deeply entrenched the way that we go about this, but it's not. I mean, it's the research is rather dated, but there was a studies that were done looking across disciplines and across psychiatry, psychology, social work, nursing. Less than it's like 23% get even an hour curricularly on the assessment and treatment of suicide risk. It's mostly on the job. And I'll go to my supervisor, like, I've got a patient, he's really freaking me out, and then the supervisor will tell you, well, I'll hospitalize him, give him medication, the very things that it can't get passed along. So that's why I'm so grateful to be with you guys today in this kind of forum, because you're receptive, and this really needs to change. Our suicide rate has just gone up. It's leveled off a little bit in 24, good, but it's just gone up. Where HIV, heart disease, all the other major killers, have trailed off. Ours just keeps on going up. And the ideation in particular keeps on going up. So that 40 years of that, and you kind of get an attitude and get a little bit of a chip on your shoulder, because it is what we do just doesn't work. And there's got to be a better way.
I identify with so much of what you're saying. I also want to share that the reason or how the Hold On campaign began, although I had been experiencing suicidal loss on so many levels for so long, and also was creative around that topic, but I had written a poem called Heartbreak Times Infinity after I read an obituary in the New York Times of Stephen Boss, aka Twitch, right? Celebrity, worked with Ellen DeGeneres, Dancing with the Stars, who died by suicide. And it starts off the layers of heartbreak. Your very own mind is trying to kill you. You act on it. Now your family is forever wounded. They're at increased risk of suicide. And there was a refrain in the poem, but hold on, your thoughts are all mixed up. But feelings come and go. The pain is not going to last. And I found a singer-songwriter, Shan Carbello, who I did not know when I hired him or even when he created the song, that he himself had experienced anxiety, depression, suicidal thoughts.
Yeah.
The song became animated as a lyric video, and he also performed it himself. And the song started winning international awards for Best Lyric, Best Song, and it ended up winning an award. It was a gold award in a Paris Film Festival. And I was feeling so pumped up about, oh my God, the song won an award. And the video included the 988 number at the very end. But similar to you, in a sense, your own experience, I was feeling so despairing because the purpose of the song and the video was to help save lives, not to win an award, and to be posted on mental health websites as an educational intervention, because the lyric itself is therapeutic. It's a way to connect through the music, and it includes the 988 number. And that was not happening. So it was as if it was easier to win the award in Paris, France, than it was to get the next door neighbor to actually use and post the video. And thankfully, when I woke up the next morning after being in such angst about this, I was inspired to start the Hold On campaign for suicide prevention.
You know, I appreciate that story more than you can know, because it's my story. I mean, I feel like we've made advances. I've won awards. I was just in Italy for a semester, and they're launching a multi-site national study in Italy of the CAMS intervention in four cities across the country. So these are gratifying things. And yet I have countless stories of disappointment, frustration, so much pushback, so much resistance. We have 7 randomized controlled trials. There are 14 open correlational open trials. I still can't get colleagues to reference CAMS in their discussions of what is effective care. And yet, I will say this, 15, 20 years ago, when I was at a Lifeline meeting, the National Lifeline meeting, and I can't remember who it was, maybe this guy Mike Hogan or David Covington, floated the idea of a 3-digit number. The room burst out in laughter. These are all the people that are on the steering committee of the Lifeline. That will never happen. It was a joke. It's reality. And the legislation, I was ancillarily involved in the legislation that helped get that passed under the previous Trump administration in a divided Congress. It had a 3% chance of passing, but by God, it did. And even though all this stuff gets very politicized, it is a watershed in our nation's history that we have now a 3-digit number. And we know that number makes a difference. There's excellent research, mostly coming out of Columbia, Mandy Gould's research, that it helps. So that's what I do is I can exhaustively, I wrote an autobiographical piece for a journal about my story. And I was like shocked to kind of look at all the setbacks, all the disappointments, literally a randomized controlled trial where we had to give back the money because the clinicians wanted to basically flip off the medical director. And yet, I and my students, as you see in the lab pictures, we are upbeat and optimistic because we know that we're on the right side of this. We know from research and from the qualitative interviews and focus groups that we do that patients like what we have to offer. It feels good to help people. We've been involved with an effort called the Hope Institute, where all they do is CAMS, and some people get dialectical behavior therapy as well. That's all they do. And I'll tell you, when you go to these clinics, the clinicians are on fire because they feel like they're helping people.
And they are.
So we were at Atlanta 2 summers ago at the Hope Institute there at Children's Hospital of Atlanta. And this woman came up to me, she said, I have worked in the ED, in the emergency department. I've done inpatient care. She had, mobile crisis. She said, I've never felt this good about helping people. The parents feel like we care about them and that we're listening to them. The kids feel like they have a say in their own treatment. And she gave me a big hug and she wouldn't let go. because it was so gratifying to feel good. There's my wife and colleagues at CAMSCare went to the Empath Summit recently. Psychiatrist named Scott Zeller developed the Empath Unit model, where all they do is take psych patients and shuffle them off out of the main emergency department, and they have them sit in very comfortable chairs with softer lighting. Staff are trained not to yell at the patients, and guess what? People do better.
Oh my goodness. Yes.
And so
Big surprise, right?
we're at the summit because we have a one-session version of CAMS called CAMS Brief Intervention, which they can do in these comfortable chairs. And we have a trial that was done in Louisiana. 40% of the patients in this trial were committed against their will, but we saw a reduction in their symptom distress, and we saw an significant increase in their motivation to live. One session, 100% done by graduate students. So so things like this kind of help with the disappointment and the setbacks, because it does feel like progress. It just feels really incremental.
Unfortunately, I'm blocking on the last name of the person I'm going to mention. During COVID, there was an emergency room doctor. Her first name is Lorna.
Yeah.
Do you remember her last name?
Lorna Breen.
Yeah, who died by suicide. And her family formed a foundation to try to help prevent future suicides and prevent spread awareness. And they've worked a lot with policy, with the government. Would that be a good pairing for you to bring CAMS to medical students? Even I'm thinking outside of the traditional training, that they're getting, for them to be aware of this. And
yeah, the Lorna Breen Act was something that we just advocated for here in DC a few weeks ago at the what's called the American Foundation for Suicide Prevention Forum, where we go up to Capitol Hill and we have 3 asks typically of members of Congress, mostly their staff, who do all the work anyway, bicameral, so the House and the Senate, and we advocate. This year we advocated for VA-related suicide prevention. I think the other ask was about lethal means safety, so like bridge barriers and that type of thing. The one that I was most excited about was written by my Congressman, Jamie Raskin. So I live here in Maryland.
Oh, yes. Who didn't his child also die by suicide?
Yeah, he lost his son, Tommy, relate. And so we have a bill called the STOP Act that Mr. Raskin and Representative Nelson out of Nebraska or Bacon, I'm sorry. Yeah, I think it's Dan Bacon, have co-sponsored. That is, again, it's sort of like, it seems like so straightforward. That would provide $30 million for the organic things that are occurring since 988 was instituted, like peer support, social workers versus police officers being the first touch contacted up in a safety check, use of artificial intelligence, good AI versus problematic AI, the Hope Institute kind of model. There are so many really exciting ideas that are mostly about averting hospital stays and emergency department visits that need support and need research. And so we introduced this bill again. It was withdrawn after the election in 2024, but it's been reintroduced, and we're trying to find co-sponsors. So these are moonshot bills, but I don't know. Garrett Lee Smith Act was voted in during the Bush administration by a voice vote because Senator Gordon Smith, lost his son Garrett Lee to suicide, and President Bush signed off on it. And that funding bill has been through SAMHSA now for 15, 20 years. This would be a similar kind of SAMHSA administered bill that would pay for these alternatives to these carceral, restrictive, punitive, shaming kinds of medical model experiences that so many people experience when they admit that they're suicidal, that we're trying to avert.
As you've been listening to all this, what's turning inside of you, or any questions or thoughts that you have for our guest today?
Yeah, Dave, I've got so much respect for you for being so brutally honest. You and I are on the same frequency. Nothing we do is actually making a difference when you really think about it. As you said, the number keeps going up and up.
Well, some things are making a difference.
There is an issue, Yeah, I mean, just like maybe at a micro, there is a difference that's, happening, at a micro. But at a macro, we failing. And I quote what you said earlier on, we in the business of suicide. It's a business. Let's call it what it is for the physicians, clinicians, psychologists all out there, institutions out there all around the world. It's a business. Now, everyone involved in this business, how many of them...
there's some validity to that in terms of like there's a business to keep beds full, which may not be in the patient's best interest. But I think it's kind of dismissive to say it's a business, because really what I'm talking about is that we're in the business of saving lives and decreasing suffering. But yes, there are elements. Big pharma and big institutional psychiatry and medical models are kind of invested in the existing model. So that's a part of why it's hard to change.
Yeah. Because the honest truth is, on the street, and I'm one of them, and don't judge me because of this, but I don't trust a psychologist, and many people are not trusting a psychologist anymore. I'm just being honest. Is it really making a difference in 2026? Is it not? There's a big question mark there. People are getting more or are more afraid to actually open up about what's going on in their life.
I don't disagree.
And they
disagree. When you look at people going to ChatGPT and the platforms, people are opening up. They're just opening up to the wrong resources. Mm-hmm. So there's actually a huge increase.
But is that like a trust in human interaction? Are we failing to trust each other as humans?
Absolutely.
Given the chaos that's happening around the world. So
Absolutely.
we would rather trust a machine than trust another human, because there's this high probability that the machine is going to love me more than a human.
What's interesting about the machines is that they actually have a very good response. The chatbots, the character AI, yeah. They actually have a fairly good response initially if somebody's talking about suicide, but they degrade as a relationship forms. And then there's something called sycophany, which is that they say what you want to hear. There's a thing called rabbit holing. So they might get on this trail that you actually should kill yourself. Let's figure out how to write the perfect suicide note and find the most lethal means. And then there's something called hallucinating, which they'll make up, the algorithm is programmed such that it will tell you something that may not be true at all, have any validity, because you never hear a chatbot say, I don't know. And so that's literally a lethal combination. At the same time, there is the potential use of AI to bring to scale a level of intervention to get, and I agree with you, to get people to humans who actually know what they're doing. But I don't disagree with you that many people are wary of mental health professionals. They should be. They're not trained. They're going to try to get rid of you. They're afraid of liability, and they don't know what actually works. And that's why I'm here, is to sort of shine a light on that and say, there's a reason that people mistrust mental health professionals, because there's cause.
Yeah. So I respect what you do. Your book, Managing Suicidal Risk, and from what I see, it comes in different editions. This book is for physicians, for clinicians, or a psychologist to do their work better. Do you want to touch on your book while you're here with us?
Sure. It's the third edition of a series that was published with Guilford Press. It's really the last installment because it really describes the whole intervention. It's the source book of the CAMS intervention, and then we have a training company that will train folks, but the book is the sort of the major resource. And it's sold 70,000 copies, which in the trade, in the book business is not too shabby. But again, it's a drop in the bucket, when you think about how many people are struggling. So we're getting there. I'm 67. I'll do this for another several years, and I'm going to hang it up. But I feel like we might be at a tipping point, but the challenges are formidable, and that's what we're talking about.
The other day, and I had shared this also with Kino. I read online. There's a young woman, maybe about 30, a Mexican woman who was a social media star, and she was found dead. The article said that suicide was a potential cause of death that they were investigating. And she had posted something shortly before she died. It was about manifesting, but she was saying she was manifesting in reverse, that she was losing things, not gaining things. So who knows if she did die by suicide, but my question to you is, let's say there's a world-known person with a zillion followers, or we respect that, we don't know that person personally, but somehow we respect that person. And then you learn that they took their life, right? And we can think of many, quote, successful, at least on the outside, people who died by suicide. And then a person who's feeling their own personal distress potentially could think, I give up. how does that person help themselves, and how do we help them?
We did a study in the 90s when Kurt Cobain from the band Nirvana
Yes.
took his life.
Mhm.
And I was at actually a suicide prevention conference when that was the lead story in the news. And I happened to be sitting with some people from the Centers for Disease Control, and it may sound crass, but we're like, okay, let's study it, because we know there's going to be all these copycats that are going to follow, especially young people who look and venerate, a person like Cobain, who's a brilliant artist and a very popular band at that time, arguably one of the leaders of the grunge rock movement in Seattle. And so we did this study to test what's called the ecological fallacy, that Marilyn Monroe or a prominent suicide is gonna sort of create copycats. And I knew the medical examiner's office in King County, Seattle. And long story short, we're gonna do prospective death investigations to see if this person actually cared about Cobain. Did they have Nirvana posters? Did they have CDs, which existed at the time, or tapes? Did they have writing or notes that made reference to Cobain? Long story short, we did what's called an interrupted time series analysis. You look at the year before, the index year where he died, 6 weeks before and 6 weeks after, and then the year afterwards to see if there's any differences between after this major event. What we found was a drop in suicides after Cobain's death. We saw one death that occurred of a 14-year-old who wrote a suicide note and killed himself exactly the same way as Cobain. We had another woman who said, in her suicide note, I did not kill myself because of Kurt Cobain. But we had a drop off. And one of the reasons was because this woman named Sue Eastgard, who's the director of the King County Crisis Center, went to the memorial service where his widow, Courtney Love, read his suicide note down to the big park in Seattle and said, you can admire Cobain, you can admire his music, but he had a lot of mental health issues that were left untreated. He actually left against medical advice from a substance abuse treatment center in Southern California. Call us instead. The exact same analysis with the calls to the crisis center significantly increased to the crisis center. This is all correlational research, but it does speak to a thoughtful and responsible way of handling a very high profile suicide like that. And the suicide rate in Australia also went down after Cobain's death significantly. So there are public health ways that we can make a difference. And what we see now, I think it's second, maybe third generation media guidelines about how to report on suicide that are not going to sort of beget copycats. And back in the day, the journalists don't tell us how to do our jobs. We're professionals. Now in journalism schools, they actually hear about this research and they're changing their reporting. So that's a good development.
Dave, how can our audience learn more about the Suicide Prevention Lab? Oh, and Kino, yeah.
Sorry, I just want to comment on Paola, the influencer that passed away. So when it comes to being an influencer in 2026 versus 10 years ago, there's this major psychological shift. Okay. I'm going to use Taylor Swift as an example. There's millions of Swifties all around the world. Now, when Paola, for example, buys the latest Nikes that's out there, automatically those 2 million followers that she has is going to want to also get the same Nikes at hers, and we're dealing with the Gen Zs now, completely different, emotionally damaged generation, that really can't handle the real world.
I don't agree with that at all. I think that's not true. I don't think that's true. I hang out with these folks. I teach these folks. I totally disagree.
I don't know, but I feel like millennial versus Gen Z, we have come, I'm a millennial and I can handle myself more under pressure versus a Gen Z,
We can disagree.
I don't know. When someone like Paola passes away, okay, and if it does get labeled suicide in the end, because there's this fine line between suicide and foul play when it comes to someone like her, I don't know whether those numbers are going to drop or increase, and that's the scary part about it.
I hear
versus,
that.
I mean, behind me is just one more comment. Behind me is a Linkin Park poster. It's like when Chester Bennington passed away by suicide several years ago, you would have seen a decrease in suicide, as Dave was explaining, being a musician, and you would have seen more awareness brought to the subject because Chester Bennington, passed away by suicide. But now when you got an influencer like Paola passing away, and if it is labeled suicide, and I don't know what the reaction is going to be with her followers globally.
It depends how it's handled. I mean, it's just a contemporary version of what happened with Cobain. There was every reason to believe that was going to create an absolute explosion in copycat suicides. It was handled properly. It's a different medium. It's a different forum, but I don't mean to be disagreeable. I don't agree with your characterization of Gen Z. I teach Gen Z. I just spent a whole semester living with 19 and 20-year-olds. What I find as a professor is that when I ask them about who influences you, they're not describing Taylor Swift. They're not describing soccer players and famous athletes. They're describing people who they are close to. So I think that the influencer movement is fascinating. I don't think we have good data on it at all. But whenever there's a celebrity suicide, it's how the larger media handles it. I mean, one of the things that came from Cobain, before Cobain, you never would see like a mental health carve out in an article. Rolling Stone did an entire issue on Kurt Cobain, but there was so much information about the resources of that time. So I'm not convinced that there'll be an explosion of suicides. There'll probably be some. But it's how it's handled and the responsibility of journalists, of people like you guys who are trying to get information out into the wider awareness, that I think makes the difference.
And that's empowering, what you said.
It is, as it should be.
Yeah.
I need to share your
say-
website with the Gen Zs in South Africa. That's what I need to do.
Maybe.
Yeah, that's what I need to get up.
I just spent a lot of time with Gen Zers, so I feel like I've got a lot of direct knowledge. And I think every generation, let me put it this way, I think every generation, I've written 2 blogs about this on the Psychology Today website. Every generation, like never before have kids ever gone through what our kids are going through today. My parents did it in the 70s and 60s. And I think what's common across the generations is much more impressive than what's different.
That's good.
Thinking
I like that.
the parents of Cain and Abel must have
I'm
thought.
before. And that came before.
Dave, how can our audience learn more about you and the Suicide Prevention Lab?
They can just Google. I mean, if they Google my name or Google the Suicide Prevention Lab or cams-care.com, that's our training website. But I mean, it's people like you and Kino that actually make all the difference. Because if I'll just talk to anybody about these ideas, because it's just so hard to change the tide. And yet, even as we've talked about discouraging things, there's also a thread of hope that comes through all this, that things can change, and that people, Diane, like you and Kino are a part of that. And if people are interested, there is a tremendous amount of information available, free and easy. Zero Suicide is a policy initiative. You can Google that. The American taxpayer paid for it. You can learn how to improve clinical care. But if you Google CAMS or Google my name, there's plenty of links you can find.
I love what you said about a thread of hope. And it reminds me, there's a poem, I think, by William Stafford, and he talks about the thread that runs through all of life and that you need to hold on to that thread. So I want to thank you so much. And the way that we met was you were presenting at a conference that I was watching and listening to online, and I put a question in the chat box, and then I think you may have responded to it during the presentation, or maybe yes, maybe no. Then I emailed you. I think you did, because I emailed back. I was the one who asked the question.
Oh, yeah.
And it just shows how gracious you are and how passionate you are to join us on the podcast. So thank you so much.
Well, thank you so much. I really appreciate you and Kino giving me this opportunity to talk about this topic. It's
We
really
appreciate you too, Dave. Thank you.
important. Thanks so much.
Hi, thank you.
Bye.